Good evening, everyone. Thank you very much for joining us today on our Africa Healthcare Network Fireside Chat series number 501. Today's speaker is Dr. Mohammed Gawad from Egypt, and he will be taking us through navigating potassium peaks and patient safety. But before I give him the mic, I would just like to briefly introduce him. So Dr. Gawad is a consultant nephrologist from Alexandria, Egypt. He's also affiliated with the Newgiza University in Giza. He is the member of the Scientific Council at the Egyptian Nephrology Fellowship Program. He holds a MD and PhD from Mansoura University in Egypt. He also holds the ESENephrology, which stands for European Specialty Examination in Nephrology. He is also a fellow of the International Society of Nephrology. He is the founder and chairman of NephroTube, a channel on YouTube. And for those who don't know about it, this is a very valuable resource. And I would really urge you to join and to actually go through the talks that Mohammed has given there. They're fairly valuable. He also gives a monthly clinical case, which I attended recently, which was quite informative. So I would suggest to all the audience to try and follow this as much as possible to improve and just revise your knowledge for those nephrologists that have been out of training for some time. He's also a member of the Egyptian Renal Data System (ERDS) committee. He's a member of the educational committee of AFRAN, and he's also the member of the African Journal of Nephrology editorial team for the visual abstracts creator. He's also the ex-chairman of the AFRAN social media committee. So with that, I would like to invite Dr. Mohammed to please take the mic and go ahead with the presentation. Thank you so much.
Thank you, dear Mazhar. It's actually my pleasure and honor to be with you today. And thank you for this nice introduction. As you asked me to present about hyperkalemia, because as you know, and all our colleagues here know, that it is a very common electrolyte abnormality that we can see as nephrologists, whatever in the acute form or in the chronic form. So the main target of today's lecture is to navigate through the hyperkalemia, the possible interventions and management for the hyperkalemia and how to maintain patient safety. I will start with this algorithm, which is the summary of all the lecture. I will start by what are the lines that we should use for management of hyperkalemia. This depends on the serum potassium level of the patient. If the serum potassium is 6 or greater than or equal 6 or not, if yes, okay, you have to ask yourself, does the patient have muscle weakness or cardiac conduction abnormalities? If yes, you have to start hyperkalemic emergency measures as membrane stabilization by intravenous calcium, using glucose, insulin, and salbutamol, potassium binder, and medication supplement review. I will go in depth for each of these steps, but I will highlight the main lines at first. If the potassium of the patient is hyperkalemic, but the potassium is less than 6, or if the potassium is more than 6 or equal 6, but the patient has no signs or symptoms of hyperkalemia, especially the muscle weakness or cardiac conduction abnormalities. So is the serum potassium greater than or equal to 5.5? And especially if you have an old potassium serum level of the patient, especially if the patient is admitted in the hospital and you know the previous 24 hours serum potassium level of the patient. So if the serum potassium is greater than or equal 5.5, and especially if it has increased more than 1.5 millimole per liter within 24 hours, if yes, this is considered as hyperkalemic urgency. So that was hyperkalemic emergency in the presence of muscle weakness or cardiac conduction abnormalities. This is hyperkalemic emergency. In hyperkalemic urgency, no need to use intravenous calcium as hyperkalemic emergency. Just you will use glucose, insulin, and beta agonist, potassium binders, and medication supplement review. If no, the potassium is greater than or equal 5.5, but there is no evidence that the potassium is increased more than 1.5 millimole per liter within 24 hours. If the potassium is more than 5.5, but there is no rapid increase, and this, as in this case, so you have to consider potassium binders in this patient, medication supplement review, and diet review. If no, so this is a borderline hyperkalemia, follow up potassium with next day labs. So this is the general approach for the management of hyperkalemia, or selecting the management lines for hyperkalemia according to the serum potassium level and according to the presence or absence of clinical manifestations. And I will consider this graph or this figure, this algorithm, as my talk outline. I will describe each point in this graph in more detail, and I also will add at the end of the lecture, beside describing this graph, special considerations for hyperkalemia in patients with CKD. We know that hyperkalemia is very common to be chronic in patients with chronic kidney disease. So I want to highlight some special considerations for management of chronic hyperkalemia in patients with CKD. So as this is my talk outline, I will start by explaining the role of intravenous calcium, the role of glucose, insulin, and the beta agonist in the management of hyperkalemic emergency and urgency. We all know that calcium use in hyperkalemia is not to decrease the potassium level. Calcium is not used to decrease the potassium level, but the main use of calcium is to antagonize the effect of potassium on the heart, because potassium favors the diastole. It increases the diastolic period of the heart, increases hyperkalemia, increases the repolarization phase of the cardiac muscle. So we have to give the patient calcium in case if there is muscle weakness or there is ECG changes, to antagonize the effect of potassium on the cardiac muscle and even the skeletal muscle. We can give the patient calcium chloride or calcium gluconate, and this can be repeated. Okay, this can be repeated. We can repeat this once or twice if needed, if there is persistent life-threatening arrhythmia. So you have to put your patient on, if there is the first ECG shows that there is arrhythmia, you have to put your patient on better on a monitor, and you give the intravenous calcium, whatever chloride or gluconate, and you have to monitor if the arrhythmia is still present after 5 minutes. If it's still present, you have to give another dose of calcium chloride or calcium gluconate, and you can give a third dose also. The second line is insulin with glucose. The main idea of insulin and glucose that insulin activates the sodium potassium pump on the cellular membrane. So the use of insulin and beta agonist also, that I will talk about later, activate the sodium potassium pump on the cell membrane, causing the intracellular shift of potassium inside the cell, and this will decreases the extracellular potassium and the serum potassium and decrease potassium level. Regarding giving glucose with insulin, the use of glucose should be adapted according to the serum glucose level of the patient. If the patient serum blood glucose is lower than 180 milligram per deciliter, can give 50 gram of glucose. If higher glucose level between 180 to 150, you can give 25 gram of glucose. If the patient blood glucose level is more, he is diabetic or she is diabetic, with blood glucose level more than 250, no need for initial dose of glucose, and you can monitor the patient blood glucose level while you are administering insulin. It is important to mention that the onset of action of insulin to decrease the blood potassium level is 30 minutes, and the duration of its effect persists for only 4 to 6 hours. This is important, so you have to know when you may be in need to re-administer again insulin and glucose in patients with persistent hyperkalemia. The third line is beta-2 agonist. The mechanism of beta-2 agonist is the same as insulin. It activates the sodium-potassium pump on the cell membrane to cause intracellular shift of potassium. To be honest, in practice, we don't use it so much. I don't know what is your clinical experience in this point. We mainly depends on insulin and glucose, as both of them, insulin and beta-2 agonists, are acting through the same mechanism. So we depend mainly on insulin and glucose. And also we avoid beta-2 agonists because there is a little evidence, it is not a strong evidence, there is a little evidence that beta-2 agonists may precipitate arrhythmia. So we are giving beta-2 agonist in a patient who already at risk of arrhythmia because of hyperkalemia. So in general, we are not using it, although it is present in the literature. We found that insulin and glucose is totally enough. The third line or fourth line is sodium bicarbonate. For sure, it is indicated in the presence of metabolic acidosis, because we all know in presence of metabolic acidosis, the hydrogen as a part of the buffering mechanism of the body, the hydrogen moves into the cells and potassium moves out in exchange with hydrogen, causing hyperkalemia. So correction of acidosis will prevent this mechanism to act and will keep potassium intracellular. But again, it is very important to mention that in these patients, we have to administer isotonic bicarbonate, IV. Don't administer hypertonic bicarbonate because it has a lot of complications. Usually, if you revise all the diseases that we are using bicarbonate in its management, it is always, nearly always suggested to use isotonic bicarbonate. To prepare isotonic bicarbonate, because it is not available in the market, actually, in our country and many other countries, you have to obtain intravenous bicarbonate by adding 3 ampoules of bicarbonate, about 150 ml, to 1 liter of dextrose 5%. Okay, you have to remove from this liter 150 ml of glucose and add instead of it 150 ml of bicarbonate. In this case, you will get isotonic bicarbonate, 3 ampoules of hypertonic bicarbonate in the glucose. The onset of duration of sodium bicarbonate is 5 to 10 minutes, and the duration is only 1 to 2 hours. All of these drugs, insulin and glucose, beta-2 agonists, and sodium bicarbonate, the main idea of their use is to increase the intracellular potassium level, the intracellular influx of potassium, and decrease the extracellular potassium level. So these drugs will not decrease the potassium load on the body. The potassium level still is high in the body, but inside the cells. So we have to use other medications that promote the loss of potassium, or other ways, not only medication, other ways to promote the loss of potassium from the body and decrease the potassium load of the body. For sure, the first line is diuretics, calories, especially if the patient, as our patient in CKD, are hypervolemic. You can use different line of diuresis. You can use furosemide. You can use combination of loop diuretic and thiazide diuretic. There are multiple lines and depends on the volume status of the patient. And if the patient is hypovolemic, to make caloresis, you have to give patient fluid to increase the urine volume and increase potassium loss. So fluids in hypovolemic patient will cause caloresis and loss of potassium in urine. For sure, if the patient has metabolic acidosis, it is better to give the patient fluid in the form of isotonic bicarbonate. And without metabolic acidosis, you can give ringerlectin. So these are the lines that can be used in hyperkalemic emergency and hyperkalemic urgency. The last line is dialysis. One of the most common indications of dialysis in acute kidney injury, mainly, acute hyperkalemia refractory to medical treatment. If the hyperkalemia of the patient, whatever the cause, is resistant to the insulin glucose, beta-2 agonists, sodium bicarbonate, and diuretics, you may be in need for dialysis. And the important point regarding the dialysis of hyperkalemic patients, that you have to suspect a rebound hyperkalemia shortly after the dialysis. If the patient is hyperkalemic and the patient went through a dialysis session, post-dialysis session, if you do a serum potassium level, you will find it low or normal. After some hours, the patient will have a rebound hyperkalemia. So it is important for patients with acute hyperkalemia that are resistant to medical treatment and are indicated for dialysis to be admitted in the hospital. And you have to follow up the serum potassium even after the dialysis for several hours, because rebound hyperkalemia is suspected, as the potassium will efflux out of the cells to the serum level, causing rebound hyperkalemia. So the patient may be in need to have several dialysis sessions to correct the all potassium load in his body. So we now discussed the role of calcium, glucose, insulin, and beta agonists that can be used in hyperkalemic emergency and urgency. The coming is potassium binder. Potassium binder is one of the recent lines for management of hyperkalemia. It can be used in hyperkalemic emergency, urgency, and even here, consider potassium binder in this situation. The main idea of potassium binder is that they are drugs that we all know that the intestinal epithelial cells are one of the most important stores of potassium. Gastrointestinal system has a high load of potassium. So the potassium binder, the main idea of potassium binders, they are in the form of resins. These potassium binders, their role is to exchange. They are resins that contain some ions. I will mention the different types in the next slide. For example, here you have one of the resins, powder, that contains sodium. Then it will exchange sodium with potassium. It will give sodium to the intestinal cells, and it will take potassium from the intestinal cells. And this resin will take the potassium and passes with stool, and this will decrease the total potassium load. Regarding the main idea of potassium binders, we have three well-known potassium binders. We have sodium zirconium. I will mention in the coming slide that sodium zirconium exchange potassium for hydrogen and sodium with the GIT. We have sodium polycitrine sulfate. It exchanges potassium for sodium. And finally, the batromer, that it exchanges potassium for calcium. Okay, so these are the available three potassium binders that act by decreasing the potassium load in the body, by increasing the gastrointestinal loss of potassium. So we have these three types of potassium binding agents. These are their mechanisms of action, as I mentioned now. Regarding their site of action, sodium polycitrine sulfonate acts on the colon. The same is batromer, but sodium zirconium acts on both small intestine and large intestine. And this may make its effect more strong than these two drugs. Regarding their selectivity of potassium, sodium polycitrine sulfonate is non-selective. It binds also to calcium and magnesium, and this will be one of its side effects, that it may affect the calcium and magnesium level in the blood. The same for batromer. It's also non-selective. It can bind to sodium and magnesium, but sodium zirconium is highly selective to potassium. It may bind to ammonia, but it is highly selective regarding ions for potassium. Regarding onset of action, for sodium polycitrine sulfonate, it is variable, maybe several hours. For batromer, it is 7 hours. For sodium zirconium, it has a very rapid onset of action. It is only 1 hour. Regarding sodium content, and it is very important because it will affect the side effects of these drugs. Batromer has no sodium content, but here, as I mentioned in the mechanism of action, here in sodium zirconium exchanges potassium for hydrogen and sodium. So it has 400 milligram of sodium per 5 gram dose. Here it has 1,500 milligram sodium per 15 gram dose. So there is a higher sodium content in both sodium zirconium sodium zirconium and sodium polycitrine sulfonate, while Patromir hasn't. Regarding calcium content, Patromir has a calcium content. Both of these have no calcium content. Regarding sorbitol content, both of these has sorbitol content. All of these contents will affect the side effects of the drugs, as I will show you now. Regarding dosing, it is very important. For sodium polycitrine sulfonate, you have to give 15 gram, 1 to 4 times orally, or if the patient is in the ICU and the patient is comatose, you can use it rectally as an enema. For Patromir, you can use 8.4 gram orally daily, and you can titrate the dose. For sodium zirconium, you can use for acute hyperkalemia 10 gram 3 times daily every 8 hours for 2 days, then 5 gram every other day, up to 15 milligram daily for maintenance. Regarding side effects, it is very famous for the sodium zirconium that it can cause intestinal necrosis. And this is one of the serious adverse events of this drug. Regarding common adverse effects, constipation and diarrhea are common with sodium polycitrine sulfonate and other gastrointestinal manifestations. For sure, it can cause hypomagnesemia because it binds magnesium, and as it binds calcium, it can cause hypercalcemia. And as its main action is to bind potassium, it can cause hypokalemia, and also can cause systemic alkalosis. Regarding Patromir, also it can cause gastrointestinal manifestations and hypomagnesemia. Here, gastrointestinal manifestations, and may cause mild to moderate edema because of the high sodium content. Also, by the way, sodium polycitrine sulfonate has sodium content, and it also can cause edema also. The next point is drug interaction. This is important to be because it is important and related to drug administration. If we use sodium polycitrine sulfonate, in Egypt we have both polycitrine sulfonate, sodium polycitrine sulfonate, and sodium zirconium. We don't have Patromir in our country. For sodium polycitrine sulfonate, you have to administer it at 3 hours before or after other oral medications. You cannot give it with other oral medications. It can affect the bioavailability of other drugs. The same for Patromir. Regarding sodium zirconium, you have to give it at least 2 hours before or 2 hours after gastric pH-dependent oral medications, because this drug affect the acidity of the stomach. So if you are giving a patient a drug that is activated or partially activated in the stomach, depending on the acidity of the stomach, this drug will not act and will not activate it if you give it with sodium zirconium, because sodium zirconium affects the pH of the stomach. These drugs are very, very, very efficient, especially the sodium zirconium. But the main disadvantage of sodium zirconium, although it has, I will show another slide, the expected result regarding the lowering of serum potassium level. For sodium zirconium, it is expected to lower serum potassium level by 1 to 1.5 milliequivalent per liter in 48 hours. This is a very rapid action. But the main side effect of this drug, and also Patromir that is not available in Egypt, the cost. It has a very high cost that not all patients can afford. So after we mentioned potassium binders, the next is to talk about special considerations for management of chronic hyperkalemia in CKD patients. Regarding management of hyperkalemia in CKD patients, I want to cover the following points. The first, what are the dietary recommendations to control potassium level in CKD patients? What are the medications that can be used in CKD patients to lower potassium level? We all know that ACE inhibitors and the ARBs are cornerstones in the management of chronic kidney disease, and we all know that hyperkalemia is one of the most common side effects of these drugs. So how to deal with hyperkalemia that is caused by ACE inhibitors and ARBs? And we all know now the most recent added drug to the management of diabetic patients with CKD, which is the finerenone, which is one of the non-steroidal mineralocorticoid receptor antagonists. And we all know also one of its common side effects is hyperkalemia. So how to deal with hyperkalemia that is caused by this drug? Let's start by dietary recommendations. What are the dietary recommendations in patients with chronic kidney disease to control hyperkalemia? The guidelines, the KDIGO guidelines, as I will show you now, emphasizes individualized approach based on patient's potassium level rather than blanket restrictions. Let's see what the KDIGO guidelines said. KDIGO guidelines mention that dietary potassium restriction is not routinely endorsed unless there is a history of hyperkalemia or increased risk of hyperkalemia. So if your patient is not hyperkalemic and no history of hyperkalemia, there is no need to restrict potassium. But for sure, the patient must the patient diet must contain potassium with an average level, not a high level of potassium. For example, the patient shouldn't eat a lot of fruits because we are not restricting him from potassium. So there is no recommendation to routinely endorse it. Dietary potassium restriction is not routinely endorsed unless there is a history of hyperkalemia. So there is no indication for blanket restriction for hyperkalemia in chronic kidney disease patients. Okay, this is what was mentioned by the KDIGO guidelines. But you have to advise your patient to limit the intake of foods rich in bioavailable potassium as processed foods, because you know also processed foods may also increase the level of phosphate in this patient. Okay, so and I have to mention that also the KDIGO guidelines recommends in general regarding the diet is to recommends the consumption of plant-based foods. So we are recommending, if you limit the potassium level in the patient, to use low potassium plant-based foods to avoid hyperkalemia in a patient with history of hyperkalemia or a patient an increased risk of hyperkalemia. Some experts may limit the potassium intake in all patients with stage 3 to 5, but actually this is not recommended by the KDIGO guidelines in chronic kidney disease, as I mentioned now. Regarding medications that can be used to lower potassium level in chronic kidney disease patient, first of all, loop and thiazide diuretics, especially if your patient is edematous. We all know that thiazide diuretic is ineffective and unuseful if the GFR of the patient is below than 30 ml per minute, because below this threshold, the thiazide diuretic effect diminishes. But loop diuretic can be used at any stage of GFR, and it's still effective even in GFR lower than 30 ml per minute. The second line in our patient to control potassium level in chronic kidney disease is acidosis management. We all know that our patient may be acidotic. You have to follow up the venous bicarbonate of the patient, and if there is low bicarbonate level in the patient, you have to correct it by oral bicarbonate. We all know that the guidelines, the recent guidelines of KDIGO mention that it is not preferred to let the venous bicarbonate of the patient to be less than 18. But actually, most of the literature recommend, and the old guidelines of KDIGO recommend to keep the bicarbonate level, the venous bicarbonate level of the patient to be within the normal range between above 22 millimole per liter. So the acidosis management of the patient will help to control the potassium level in chronic kidney disease patient. As we mentioned, acidosis management in the beginning of the lecture promote intracellular shift of the potassium. The third is potassium binders. I had just discussed potassium binders and how we can use. So in patients with chronic hyperkalemia who are resistant to other lines of management, for say you have a patient, chronic kidney disease with chronic hyperkalemia, you revise the diet of the patient and you are sure that the patient is not taking a high potassium diet, you administered in the patient loop or thiazide diuretics, and you corrected acidosis of the patient, and there is still hyperkalemia. In this case, you can use potassium binders. And KDIGO guidelines mention that these drugs play a key role in the management of chronic hyperkalemia, especially in patients on RAS inhibitors and finerenone, as I mentioned now, because these drugs are very important for your patient and they may cause hyperkalemia. So you may be in need to use potassium binders. Okay, and we talked in detail about these potassium binders. Sodium glucose cotransporter SGLT2 inhibitors can lower potassium in chronic kidney disease. For sure, we are not using them or they are not primarily indicated to lower the potassium level. They are used to delay the progression of the chronic kidney disease, SGLT2 inhibitors. But by the way, we found that, or they found that SGLT2 inhibitors reduce the risk of hyperkalemia in patients of CKD, as they have diuretic effect and calorific effect, so they can help in the management of chronic hyperkalemia in chronic kidney disease patients. So these are the lines or medications that should be used in our patient, especially for those with chronic hyperkalemia. So we discussed the dietary recommendation for management of hyperkalemia in patients with CKD. We discussed the medications that can be used to lower potassium level in chronic kidney disease. Now, what about ACE inhibitors and ARB use? First, we all know that ACE inhibitors and ARBs that we are calling RAS inhibitor, the recent evidence showed that ACE inhibitors and ARBs should be continued even in advanced chronic kidney disease patients. So very recent evidence by KDIGO suggests against RAS inhibition discontinuation in advanced CKD. And they recommended to continue RAS inhibitor even if the eGFR is less than 30 ml per minute, unless there is any of the following. If there is refractory hyperkalemia, you have to stop them. If there is symptomatic hypotension, you have to stop them. Or if there is any other contraindication for the use of RAS inhibitors, you have to stop them. This evidence, the evidence of the continuation of ACE inhibitors or ARB, even if the GFR is below than 30, is based on one of the mega trials, which is called STOP ACE trial. The STOP ACE trial demonstrated that discontinuation of ACE inhibitors or ARB didn't improve kidney function. This is a comparison regarding the GFR between the group which continued ACE inhibitor and ARB and those who discontinued ACE inhibitor and ARB. Thus, the discontinuation of the RAS inhibitors didn't improve kidney function, or even it didn't delay kidney failure. It didn't delay the need of renal replacement therapy for end-stage kidney disease. So there is no fear for, we all know that ACE inhibitors and ARB, they can be nephroprotective and at the same time they can be nephrotoxic because they cause efferent arterial vasodilation and decrease the intraglomerular pressure. From here we get a benefit by decreasing proteinuria and decreasing the hemodynamic stress. But at the same time, the decrease in GFR may cause kidney injury or a form of acute kidney injury. And in the past, we were always afraid to continue ACE inhibitor or ARB in patients with low GFR because we are afraid of a rapid deterioration of the kidney function. But as you see in this new evidence that even the continuation of ACE inhibitor or ARB with GFR below than 30, there is no fear of the use of ACE inhibitor or ARB. So now we know that ACE inhibitor and ARB are mandatory for CKD patients. What if hyperkalemia was developed by the use of RAS inhibitor? Regarding the use of RAS inhibitors, the traditional protocol that before you prescribe for your patient ACE inhibitor or ARB, you have to make a base level test for both creatinine and potassium. Then you have to follow up potassium and creatinine again after 10 days to 2 weeks. If the serum potassium is more than 5.5 and the patient, I am 100% sure that the cause is the use of RAS inhibitor, what I have to do? And if the serum potassium is more than 6 millimole per liter, what I have to do? If the patient is on ACE inhibitor ARB and the serum potassium is more than or equal 6, RAS inhibitor therapy should be discontinued if potassium is persistently more than 6 despite attempts at medical management. You have to try the lines of management of hyperkalemia, and if the potassium is persistent more than 6, you have to stop it. And some experts discontinue RAS inhibitor temporarily in these cases. The serum potassium level is more than 5.5. Some experts recommend dose reduction or temporary cessation of RAS inhibitor. But the KDIGO guidelines, 2021 guidelines for the blood pressure management CKD, suggested that potassium more than 5.5 but less than 6 in patient of RAS inhibitor can be managed by lines that we mentioned as review of the dietary intake, review if the patient is using other potassium raising agents as non-steroidal, review if the patient is in volume depletion, exclude renal artery stenosis. And they highly suggest the use of the novel potassium binders, as I mentioned, sodium zirconium or batromere, to control the hyperkalemia associated with RAS inhibitor use, rather than stopping or discontinuation of RAS inhibitor. These drugs, the novel potassium binders, give us a very wide room to use RAS inhibitor, even with advanced CKD, without to be fear from hyperkalemia, because they can control hyperkalemia effectively. So KDIGO guidelines in serum potassium level between 5.5 and 6, they don't recommend the discontinuation of RAS inhibitor as some experts recommend, but try to search for the cause and try to control hyperkalemia with novel potassium binders. So this is regarding ACE inhibitors and ARB use and their relation to hyperkalemia. What about our new weapon in CKD patients, which are non-steroidal mineralocorticoid receptor antagonists? I have to mention first that finerenone is currently the only mineralocorticoid receptor antagonist with proven clinical kidney and cardiovascular benefit. And as it is recommended by our recent KDIGO 2024 clinical practice guideline for evaluation and management of chronic kidney disease, finerenone may be initiated in patients with diabetes and chronic kidney disease with persistent albuminuria, despite a maximum tolerated dose of ACE inhibitor or ARB for more than 4 weeks, provided that the following criteria are met. The GFR must be 25 ml per minute or more. The serum potassium should be within normal range, because for sure, mineralocorticoid receptor antagonist will cause hyperkalemia. That's why it is important to adjust the dose of mineralocorticoid receptor antagonist, non-steroidal mineralocorticoid receptor antagonist, according to potassium level, because for sure it will cause hyperkalemia. The starting dose depends on the GFR of the patient. We have a protocol if the GFR is 60 or more, and we have a protocol if the GFR between 25 and 60. Below 25, we will not start finerenone. At first, the starting dose, before starting the drug for the patient for the first time, the serum potassium should be totally normal. If the GFR between 25 and 60, start by 10 milligram once daily. If GFR more than 60, start by 20 milligram once daily. Then you have to adjust the dose based on follow-up serum potassium concentration. What is the frequency for following up serum potassium concentration? You have to monitor serum potassium 1 month after initiation. After initiating the drug the first time, you have to monitor potassium after 1 month after initiation. And if the potassium is good within the normal range, you can also have to start to monitor serum potassium 1 month after initiation or after starting the treatment. If you stopped the treatment for any reason and you restarted the treatment again, you have to monitor the potassium after 1 month. Or if you increased the dose of the patient, as I will show you now, you have to reassess again the potassium after 1 month. If the potassium is accepted and there is no restarting of the treatment or no new dose adjustment, you can follow potassium every 4 months. So what is the dose adjustment? If the potassium during monitoring is 4.8 or less, here you will maintain the 20 milligram per day dose. For this patient, you can increase the dose from 10 to 20 milligram once a day. If the potassium is between 4.8 and 5.5, here keep the 20 milligram once a day, and here keep the 10 milligram once a day that you have initiated before. The potassium is more than 4.5. In the follow-up, you have to stop the treatment and consider restarting. For this patient who you started at first with 20, restart at 10 milligram once a day when serum potassium is less than or equal 5. Regarding this patient, consider restarting again at 10 milligram once a day when also potassium is less than or equal 5 milli equivalent per liter. So I discussed in details how to control the potassium level in patients with CKD, chronic hyperkalemia with CKD, the different lines regarding the dietary recommendation, medications to lower potassium level, and how to handle the hyperkalemia that is associated with ACE inhibitor and ARBs used, and the hyperkalemia that may affect the use of non-steroidal mineralocorticoid receptor antagonists. Finally, my home messages: prompt recognition and timely intervention are crucial to prevent complications like cardiac arrhythmias that can be caused by hyperkalemia. ECG changes can provide critical clues to hyperkalemia severity and the urgency of treatment. Treat the precipitating factors, such as adjusting medications, correcting acidosis, or managing tissue breakdown if you are suspecting rhabdomyolysis, for example, in cases of acute hyperkalemia. Engage a multidisciplinary team is important, including nephrologist, cardiologist, dietitian, for comprehensive management of hyperkalemia. And the dietitian role is very important, especially in patients with chronic kidney disease. Thank you for your watching.
Thank you very much, Gawad, for that concise yet comprehensive presentation, specifically on the treatment of hyperkalemia using both the traditional methods and the newer methods that have come through. And I think it's very important that you mentioned about chronic kidney disease and the use of ACE inhibitors in ARBs, because at least where I practice, I've noticed majority of the patients that come to me were on ACE inhibitors or ARBs, and they've been stopped because of the concern of deranged kidney function, and they may be using that for either heart failure or for hypertension, as you mentioned. And it is more detrimental to stop the drug rather than just taking the necessary mitigating factors. So I think that is very important. And I think the Stop ACE trial that you did mention is something that everybody should at least read it to just get an idea of how best we can deal with these things. So maybe just before we go to the questions, we have got a few questions. Maybe if I can just ask you one or two questions from my side.
Okay.
So the one thing that I wanted to ask you, with the traditional method that we use, the calcium gluconate, the insulin and glucose, so how quickly can we give the insulin and glucose? And also, how soon can we repeat it if, say, the potassium is still elevated? And secondly, with regards to, I know you based more on potassium binders, but what about, say, for example, if you are in a setting where you don't have these potassium binders and you have, say, lactulose or sorbitol, can you use that? And again, how frequently can you use that? Thank you.
Okay. Regarding the use of insulin glucose, we actually use 10 units of act rapid insulin in 500 ml of 5% dextrose, and we can repeat them after 5 to 6 hours because their duration of action is about 4 to 6 hours. So we don't repeat them before that. Regarding the second question regarding the potassium binders, I know that they may not be available, and I know that they may be expensive for some patients. The other option, I try to control the potassium in the diet. If I failed, I have no experience in the lactulose use, and because the recommended normal dose of the lactulose that is not causing diarrhea, it will not cause effective potassium loss from the gastrointestinal system. And regarding the sorbitol, we are afraid from intestinal necrosis that may affect the patient from the use of sorbitol. So its use, it may be dangerous. So this is a risk-benefit situation. I may think if the patient has advanced chronic kidney disease and hyperkalemia, but he has advanced chronic kidney disease and he is near dialysis, I will not risk by using lactulose or sorbitol if it is the only option. But if the patient is young age and early stage of CKD, and the ACE inhibitor ARB and, for example, finerenone is very important, I may take the risk with close monitoring for the patient, but actually there is no evidence of that. This is just an opinion.
Understood. Thank you, Gawad. Yuri, you raise your hand.
Yes, Yuri.
Yes, thank you, Dr. Gawad. Quite an enlightening discussion there. So first, I have a comment, then two questions to follow. My comment is, I think I appreciate I think you mentioned that there's no blanket recommendation for a dietary recommendation in terms of reducing foods containing potassium. I think that's good for even our audience to just think about, unless now there's a prior history of hyperkalemia or a challenge. I think that is quite important because we're always very scared. We have a CKD patient on dialysis and you're like, if we don't have these discussions early, it might get to a point that maybe when the Ks are rising, it's hard for them now to, switch to the low potassium containing foods. So that was just my first comment. Now, I want to pick your brain on something to do with adjusting the dialysate potassium. I think it's something that has been talked about in different schools of thought. You say like an example, case scenario 1, you have a patient with Ks of about 7. You decide to adjust the dialysate. Probably you just want to tailor it to the patient, probably use around 2 millimoles thereabout. But now the challenge is it kind of ends up to be like a vicious cycle whereby you end up removing potassium more efficiently, but you might increase the risk of arrhythmias because there's rapid shifts in serum potassium and magnesium. So the same thing that you're trying to prevent, you end up now causing arrhythmias and even death intradialysis. So that's the first question. On the second one that I find to also be quite of a challenge, I think as you mentioned when you were speaking about the potassium binders, you get a patient who is, I can say, in the lower socioeconomic profile, is anuric, already non-compliant to the prescribed renal diet. So you are trying to, and you find they have hyperkalemia, sodium is high, the BP is up because they're having fluid overload. So you decide to maybe prescribe some potassium binders. Now, what is available in the market and is cheaper? It's probably the sodium polystyrene options. The Patiroma and sodium zirconium are a bit expensive, out of reach, also not very available. But now the issue with now the sodium, is there now a risk of also having, adding sodium load and worsening the hypertension and thirst in the patient when you're using the sodium polystyrene option? Of course, the other complications, as you mentioned, constipation, bowel necrosis and all that. But now it becomes a vicious cycle that you're adding more sodium. So the BP shoots up, again, more fluid overload because of thirst, then you start giving more antihypertensives. Thank you.
The second question is related to a dialysis patient or patient not on dialysis?
Yes, dialysis patient who's anuric and non-compliant to prescribed renal diet. You try to, from time to time, of course, profile the sodium, but yes, all right.
Regarding your first question and the risk of low dialysate potassium and the risk of arrhythmia, you are totally right. Low potassium level is not recommended at all in hemodialysis patients, as it increases the risk of hyperkalemia. If the patient comes for first time for hyperkalemia and the patient is on hemodialysis, I will treat him as acute hyperkalemia. If potassium binders are available, I can use it, and I can dialyze the patient for several days, short daily dialysis for 3 or 4 days to correct the hyperkalemia and maintain the potassium level within the normal level, and then reschedule the patient again on his or her every other day dialysis regimen. This is the only option that I have, and this is also the option that I will use for your second patient. If the patient cannot take sodium polystyrene sulfonate because it is not available, or because of you are afraid of hypernatremia and thirsty and increase water intake and so on, the only option that may be used is to increase the dialysis frequency. I don't have other option because no other available potassium binders are available and you can introduce, or I will take the risk to use the cheapest potassium binder, which is sodium polystyrene sulfonate, and I will monitor the patient sodium level and the fluid intake till I correct the potassium level of the patient. We have no many tools in the patient on dialysis because you're already correcting acidosis by dialysis. If the patient is anuric, you cannot use diuretics. So you have no line except the dietary management and the potassium binders, or to increase the dialysis frequency and dialysis duration.
Thank you for that response. I think the third challenge with that is you find patients are not able to afford the additional sessions. But
yes,
yeah, I do get it.
We have in Africa challenges that are not present in textbooks. We needed to make textbooks specified to Africa. I know these situations very well.
Sure. Thank you for that reaction. Thank you.
Thank you, Ray, for those questions. Prof. Bima, your hand is up.
Thank you, Dr. Gawad. Thank you very much for that very enlightening talk. I really enjoyed it. So I'm a pediatrician, but I'm not going to ask you a pediatric question. I'm just going to stick to what you said. I'm just very intrigued by preparation of isotonic bicarbonate. So there's three questions, all related. So in South Africa, we have two strengths of bicarbonate, 4.5, 8.5. So which one are you referring to? Second one is the volume. So we have it comes in a 10 ml vial or a 50 ml vial, right? So are you talking about the 10 ml or 50 ml? And the third question is that how rapidly do you give it, infuse it?
Okay. Regarding which sodium bicarbonate we are using is the hypertonic one, which is 8.4%, the 50 ml of it. We use 3 bottles. Yes, we use 3 bottles, 100 ml, 150 ml, and I get 1 liter of dextrose. I distract 150 ml from dextrose itself outside the bottles. Then I add the 150 ml of the sodium bicarbonate to the remaining 850 ml of the dextrose. This mix is isotonic sodium bicarbonate. I infuse it very slowly, especially if the patient is severely acidotic, because we all know the risk of rapid correction of metabolic acidosis and the rebound hyperkalemia. On how long I give the infusion, there is no exact infusion rate that I can tell you about, but I at least I give it on 1 hour or even more, and I monitor the venous bicarbonate and pH of the patient during the infusion of the sodium bicarbonate.
So I mean, I'll tell you my own experience. I give it over 4 hours because after 4 hours we check the potassium again, right? So that bicarbonate is gone in and check it again. But I mean, 1 to 2 hours, I guess it's fine, because if you give it too rapidly, you just compare change bicarb to CO2, and so there's no value. See? So the problem is, we of course in pediatrics have to tailor make the volume, etc., to the needs of the child. You know what I mean? Because you can't give a neonate 1 liter of fluid. You see, but anyway, that's for pediatrics, so I'll do that. But thank you very much. I really appreciate that.
It's my pleasure.
All right, Gawad, I know we are all over time, but there are a couple of questions in the chat. So if you don't mind me going through them. Sure, thanks. So the first question is with regards to usage of Ringer's lactate. Ringer's lactate has potassium inside. So the question is, how can we give Ringer's lactate in patients with hyperkalemia without metabolic acidosis? I believe you mentioned this as part of hydration and calories.
It is not mandatory to be Ringer lactate. You can use any balanced crystalloid if you are afraid from hyperkalemia. But also the volume that we can use, it depends on the volume status of the patient. What is the severity of hypovolemia of the patient? If it is mild, you can use only half liter of Ringer lactate. If the volume of replacement is high, you can use Ringer lactate in exchange with other balanced crystalloids. It is not mandatory to be always Ringer lactate.
Okay, thank you, Gawad. So it all depends on what the status of the patient is, and basically individualize the patient, not increasing the risk. Okay, so Abir has got a couple of questions. The first question is asking is potassium binder effective in patients who have constipation? And the second question is, can you use finerenone for CKD patients without diabetes?
Okay, regarding potassium binder effectiveness in patients with constipation, no, it will not be effective. You have constipation, and the risk of gastrointestinal side effects, especially intestinal necrosis, increases in patients with constipation. So you have to be, and these drugs themselves can cause constipation. So constipation, I think it is considered one of the maybe relative contraindication to use of potassium binders.
Right. And what about use of finerenone for CKD without diabetes? Is it something that we can use?
No evidence till now, but I'm 100% sure that the evidence will come within the coming 2 to 3 years. I see some experts, this is an expert situation, use finerenone now for any proteinuric patients, even in glomerulonephritis. But this is not based on any trials. We have no RCT till now recommending the use of Renal for CKD without diabetes or for any other indication in chronic kidney disease patients.
Yeah. So I think it'll be similar to what. Yeah. Sorry. Go ahead.
What happened to SGLT2 inhibitors?
Yes, exactly.
Yes.
That's what I wanted to say. Yes.
Yes. By logic and theoretically, yes, we can use it, but we have no clinical evidence.
Yes. Yeah. So that's what I wanted to say, that when the SGLT2s initially came out, they were used for something else, and then they showed that they had kidney benefits, and then later on, trials were then specifically designed for kidney outcomes. And as we go on, we can see that we can use it at even lower GFRs now. So I think it's the only time when finerenone will be used in that way as well. So thanks for that. There's another question. Is that why continue RASI in ESRD dialysis and ESRD non-dialysis?
Okay, regarding its continuation, we continue it in patients who didn't reach dialysis because of its renoprotective effect. We are trying to decrease proteinuria. We are trying to delay the progression to dialysis. And also for their cardioprotective effect. This is the most important to continue its inhibitor in patients with advanced CKD. GFR below 30 is the cardioprotective effect of these drugs more than the renoprotective effect. Regarding their use in patient on dialysis, they can be used as anti-hypertensive medications. They are one of the lines. And also they can be used for their cardioprotective effect, especially in patients with heart failure and cardiac conditions.
Correct. Yeah, so I think that is important, that it's not just for the kidneys, it has a holistic approach to that. So the benefits are far more better than just kidney protection. So that is something that one needs to be taken into consideration. Okay, I think you've already answered this question. Role of Ringer's lactate in hypervolemic hyperkalemia as Ringer contains potassium. So you've already answered that.
Yes, if you use the Ringer lactate in low dose, low volume, it will not cause hyperkalemia or exacerbate the hyperkalemia.
Okay. The next question by Walid is what about hyperkalemia on dialysis patient who follow all dietary recommendations and not on any medication causing high potassium, but potassium is always above 6 with history of cardiac arrest?
I have to search for other endocrinal causes of hyperkalemia. You have to exclude, and by the way, please tell the patient to make a diary for his diet intake. He may be using some of the unknown plants or whatever that may cause hyperkalemia. And you have to review for other endocrinal causes that may cause hyperkalemia, because it is not logic to have a cause in this patient. If finally you didn't find any cause, I think this will be a case report and you have to publish it. And you have to dialyze your patient, yes, daily.
Yes, correct. That's something that I wanted to also suggest, that you need to make sure that the clearance is adequate enough to make sure that the patient is dialyzing properly. So it is something that may need to be investigated further to make sure that you've ruled out all the causes of hyperkalemia in this patient.
Adequate dialysis must be revised, as you mentioned, Mazhar. But if there is a problem in the adequacy of dialysis, especially of the same machine, you will find the hyperkalemia in many patients, not only one patient.
Correct. And meaning that the access of the patient, if the patient's access is poor and is unable to meet the clearance, that may be another problem for the patient.
You are right.
All right. Okay, so there is another question. I think you mentioned this in the talk, but maybe just for revision. Elihiruma is asking, how about the usage of salbutamol for hyperkalemia?
We don't use it because insulin glucose acts by the same mechanism. And we found that insulin glucose are sufficient without the use of salbutamol. And as I mentioned, there are some little evidence that salbutamol use may cause arrhythmia in these patients. So we avoid them in general because other lines are sufficient to control hyperkalemia.
Correct. And also you need to use very high doses of salbutamol, but also the effectiveness in the sense that the amount of lowering of potassium is also not very measurable, in the sense that it may be very unpredictable. So you would be giving very high doses. Risk of arrhythmias is there anyway to start off with, and then these are sympathomimetics, so it increases the risk even more, and you're not really sure how best it can bring the potassium down. So might as well just stick to what you have that is effective. All right. Another question is for SGLT2, if we start and if eGFR goes below 20, we don't stop it. We don't stop. Is it the same with MRA? So if the GFR drops with SGLT2, the same thing would happen with MRAs. We don't usually stop. So we don't stop the MRAs as well?
No. The recommendation is to stop minirenon if the GFR is below than 25. No recommendation to continue it till dialysis till now. But it will appear within the coming years, yes.
Yeah. Okay, right. The final two questions, Gawad.
Yes.
What is the mechanistic link between chronic low-grade hyperkalemia and arrhythmic risk in CKD patients compared to acute rises? And number two is, how reliable are current predictive tools for hyperkalemia and CKD, and what biomarkers are being explored?
Regarding the second question, I am not oriented by effective clinical predictive tools that are used for hyperkalemia. There may be some small trials. I don't know them. And there is no biomarkers explored for suspecting hyperkalemia rather than potassium itself, or maybe there are biomarkers, I don't know them. If the one who is asking can have any experience, he can tell us. Regarding the first question, I didn't get the question actually. Can you explain it more?
So the question is if there is a link between chronic hyperkalemia and arrhythmia risk in patients with CKD compared to acute rises.
Yes, there is small trials, also not mega trials, that chronic low-grade hyperkalemia and chronic kidney disease patients, especially on patients with longer dialysis duration, and especially in patients with left ventricular hypertrophy, this chronic low-grade hyperkalemia may precipitate arrhythmia with time. Regarding acute hyperkalemia, the risk of arrhythmia in CKD is higher than general population without chronic kidney disease.
Thank you, Gawad. I don't see any further questions. Thank you very much for your presentation. Thank you very much for your talk. We really appreciate you being on the Fireside chat. It was a very enlightening talk, and thank you very much for staying over time and answering all the questions. I must give you a shout out again for your channel and for the cases that you're presenting, and for those who are still online, please go to YouTube and just search NephroTube and go through those talks, and you will learn a lot. The last case that I attended for the case of the month was very enlightening, and I would suggest that people follow this to try and make sure that they keep themselves up to date. Thank you so much.
And please, Mazhar, on the nephrotube.com website, you will find free books about hemodialysis and the chronic kidney disease that I published last year. They will be very effective. Yes.
Great. Thank you so much. While I was thanking you, somebody sent out a question. Do you mind taking that?
Yes, no problem.
All right. So the question is, what factors increase the risk of hyperkalemia in dialysis patients, and how do we prevent these?
Okay. The most common factors, first is the diet. Second is the use of medications that may cause hyperkalemia. And the third is inefficient dialysis, whatever the cause. Short duration of dialysis, the patient is dialyzing for only 3 hours, the patient is missing dialysis, there is a problem in the vascular access, as Mazhar said. These are the most 3 important factors that may increase hyperkalemia risk in dialysis patients.
Okay. And the prevention basically is addressing those causes, so the risk factors that have been addressed. Yeah. All right. So thank you so much, Gawad, and hopefully we can see you again on this forum soon, perhaps maybe sometime next year. I'll reach out to you. Thank you very much, and I wish you a good evening.